What have we achieved in the meantime? And Michael Böhm already introduced you to the clinical program that has been set up. First, off-medication trials where patients without any antihypertensive medication were treated with renal denervation or sham, and this has to be considered as the proof of principle, the proof of concept on whether or not renal denervation can indeed lower blood pressure. The trials were positive, indicating that interfering with this interaction indeed has an effect on blood pressure. The on-medication trials, a clinically more relevant scenario where patients on antihypertensive agents 1, 2, or 3 were treated with renal denervation or sham. And this provides the evidence that denervation lowers blood pressure also in the context of antihypertensive medication. And I'm sure that most of you will agree this is clinically the most relevant patient population, since most of the patients that we're considering for this approach will have antihypertensive medications on board. These are very carefully conducted, randomized sham-controlled trials. This is far away from clinical practice, but even more important than these studies probably, besides then identifying on whether or not this lowers blood pressure, is to understand how safe and efficacious renal denervation can affect blood pressure in real-world scenarios. And there the Global Simplicity Registry is of utmost importance. It's the largest evidence base of renal denervation, more than 3,000 patients enrolled up to date, and this will, of course, provide very meaningful information on durability and safety outcomes in real-world setting. What have we learned? By any means, renal denervation appears to be safe. This is a very important outcome also when considering renal denervation for patients with uncontrolled blood pressure. We have to understand that the risk-benefit ratio is pointing towards the benefits also because the risk of this procedure is very low, and there is a recent meta-analysis published, 50 trials, 5,800 patients included, where you can see that the incidence of renal artery stenosis, for instance, as a vascular safety endpoint is 0.2% per year, so below what would we expect as the natural progression of renal artery stenosis in a high-risk patient collective. On the right side, you can see that there's also a meta-analysis published on renal safety, clearly showing that there is no statistically significant impact of this procedure on renal function, measured here as eGFR. So what, in a nutshell, do these clinical trials provide? They provide first that when you conduct them very carefully using gold standard methodology, there is no sham effect. This is very important, shown here on the left-hand side for the off-medication pivotal study of this device, where denervation had a significant reduction in 24-hour systolic and offer-systolic blood pressure as a consequence, no change in the sham group. You can see that these blood pressure changes persist over 3 years, and this is a paper where we looked into the outcomes of the on-med studies 3 years post randomization, and you can see that we're now talking about a progressive and sustained blood pressure reduction, 18.7 millimeters of mercury for 24-hour systolic blood pressure and 21 for office systolic blood pressure. On the right side is the Global Simplicity Registry at 6 months and 3 years, and pretty much the same. There's a progressive and sustained decline observed in both 24-hour and office systolic blood pressure. This always-on effect is something we have to keep in mind also when considering renal denervation for patients in clinical practice. What is meant by this always-on effect? What we're seeing actually is a reduction hour by hour provided by renal denervation, and this is distinct to antihypertensive agents where you have peak and trough actions of blood pressure lowering agents, of course, but here you can see that hour by hour the blood pressure is lower in the denervation group as compared to the sham group. And when then looking into patients with a systolic blood pressure of below 140 at 3 years, you can see that almost twice as many patients receiving renal denervation had a systolic blood pressure below 140 as compared to the sham group. So indeed it adds on to the antihypertensive armamentarium, providing more patients a blood pressure lowering of below 140 besides the blood pressure lowering efficacy that I'm showing here, where you can see that not only the office and 24-hour blood pressure, but also distinct patterns of 24-hour blood pressure are significantly reduced. The morning systolic blood pressure, which is indeed very closely associated with a stroke risk, has been significantly lowered in the ONMED study, 20.6 millimeters of mercury at 36 months. For daytime, 18.3, and for nighttime, 19.3 millimeters of mercury. All this was statistically higher in the denervation group as compared to sham-treated patients. Well, what we have learned from diabetes trials is not to look at a single point measurement, but rather look into a longer period to assess the effectiveness of any intervention, including blood pressure lowering interventions. And what we did here is we looked into time in a target range. So this is a methodology which is quite well accepted. It uses several points to calculate the proportion of a patient that he or she spends within a desired range. And we have defined this desired range here as a systolic blood pressure of below 140. And when you look into the SPRINT trial, for instance, this TTR is an established assessment of blood pressure control and represents an independent predictor of cardiovascular risk. So a time a patient spends then below a certain blood pressure threshold was also calculated using various databases with renal denervation patients. We have looked into the spiral HDN ONMED trial through 3 years, where you can see in the dark blue line here the combined renal denervation office or ambulatory blood pressure time and therapeutic range as compared to the sham group in gray. You can see that 34% of the patients in the denervation group spent 34% was the time and target range in those patients treated with renal denervation as compared to 19% in those patients who were treated with sham, so almost twice as high. When we look into a real-world setting, and this is for the first time something that provides then also information on outcomes which may be lacking, we have confirmed that this approach lowers blood pressure, but do we know whether this blood pressure lowering then also translates into improved outcomes is something that you can look at in large databases, which we have did in the Simplicity registry. And here, what you can see is in this large cohort of patients with more than 3,000 patients enrolled, you can see that throughout 36 months of follow-up, the time in target range increased from 28% to 35%. And then calculating, and this is a nice example of what that means, so then calculating what that associate or how TTR associates with a cardiovascular events is an important step in understanding on whether or not this blood pressure lowering then may also translate into improved outcomes. What you can see here is red indicates those patients with 0 TTR, yellow 50 or below, and green indicates patients with more than 50% of the time spent in target range. And for the first time, we showed that there is a clear association indicating that the lower the time in target range is, the higher is the rate of MACE, cardiovascular death, myocardial infarction, and stroke. So what can we say? We can say that indeed denervation improves TTR, and the higher the TTR rate is, the lower is the cardiovascular event risk in these patients. You can calculate then the associated relative risk reduction with the blood pressure lowering. This is something which has been done here, looking into MACE rate, cardiovascular mortality, myocardial infarction, and stroke, and all this turned out to be statistically significant as compared to a calculated control event group from a historical control. So, for instance, MACE rate was relatively reduced by 26%, cardiovascular mortality by 16%, myocardial infarction by 21%, and stroke by 34%. And then you can model that, of course, through not only 3 years, but also 10 years. And if you do that, you'll find that renal denervation associated with a 26% relative risk reduction in all GSR patients when you model this over 10 years of follow-up. So What does that mean in various and distinct subgroups of high-risk patients that were mainly excluded from the ongoing sham-controlled studies? And this is something we can do with the registry. This is a very valuable database to do these analysis. We looked into patients with resistant hypertension, patients with diabetes, CKD, and elderly individuals. And of course, the higher the baseline cardiovascular risk is, the greater is the relative risk reduction. That ranged from 21% to 33% in these high-risk subgroups. So in summary, what we have shown is that denervation indeed lowers blood pressure, not only in sham-controlled studies, but also in real-world databases. We have seen that blood pressure reductions following radiofrequency renal denervation are present throughout 3 years of follow-up at least. We have associated TTR with reduced risk of MACE and other events, including stroke, myocardial infarction, and heart failure within 3 years. And of course, you can model that then into improved outcomes throughout longer follow-ups. Thank you very much for listening.